Good afternoon to all, but also good morning and good evening to many of us. It's our pleasure to welcome you to the ITM Alumni webinar organized in light of World NTD Day. It's the first one ITM Alumni webinar of 2023 as well. In this webinar, ITM alumnus Wendemagegn Enbiale Yeshaneh will share his research findings on the integrated control of skin NTDs in Ethiopia. The main aim of the ITM alumni webinars is to share research findings, expertise, and experiences on a specific international health topic within the ITM community of alumni, staff, students, partner institutions, and the wider global health community. I will now briefly explain some of the practicalities of the webinar. If you want to ask a question, you can use the Q&A option you will have below your screen. If you want to ask a question in live, you can raise your hand. The chat is being disabled for questions. Questions will be moderated and only a select number of questions can be answered in live given the limited time. Unanswered questions cannot be answered individually afterwards, for which we apologize. At the end of this webinar, a short survey will be displayed and a browser window will open to give your feedback. The webinar is being recorded and will be made available afterwards on the ITM Alumni platform and YouTube channel. I will now give the floor to our today's moderator, Professor Dr. Johan van Griensven. Johan van Griensven graduated with a medical degree from the Catholic University of Leuven and is trained as a specialist in internal medicine in Leuven and South Africa. He is currently professor in neglected tropical diseases and works at ITM since 2008. He has previously worked and lived as a clinician and researcher in Botswana, Rwanda, and Cambodia. In 2015, he founded and still heads the NTD unit at the Clinical Science Department of ITM with the aim to develop a clinical and immunological research line on leishmaniasis and other NTDs. Johan, the floor is yours.
Can you start the video or we do it without?
Yes. Yes.
So welcome to all of you. It's a pleasure to have you all on the webinar. The core components will be a presentation by my colleague Wende, and then I'll try to moderate some of the questions from your side. So Wende is a long-standing colleague and friend from Ethiopia. He's a dermatologist, but also has a master's in public health from Manchester University and a PhD from the University of Amsterdam. In the PhD, he mainly focused on podoconiosis and scabies. He's having a leading role on NTDs within Ethiopia and at the international level through supporting WHO and other activities. Wende, you have the floor.
Thank you, Johan, for the introduction, and I'll be sharing my slides. So again, good afternoon, everybody, and good morning for those who are in the West, and good afternoon and good evening for those who are in the East. And my presentation is on the integrated control of skin NTDs in Ethiopia, especially the concepts and potential synergies in the realm of resource limitation. So on this presentation, I'll be will give you some background on especially skin NTDs, especially skin diseases and skin NTDs, and the rationale for integration of skin NTDs. I'll go through the challenge for the integration. Then we'll focus into the Ethiopian scenario, and starting from the dermatology clinic to what we are doing in the community. And through this, we'll be mentioning also some of the studies, especially some of the operational researches on community-based interventions, individual management, and plus also community engagement. So when we are talking about skin diseases in general, skin conditions are estimated to affect more than 900 million people globally each year, and it ranks as 18th leading cause of global burden of disease. So they are also one of the top 10 causes of non-fatal disabilities. And the skin is the first and most valuable visible structure of human body for both patient and healthcare personnel as entry point for diagnosis and treatment of especially internal diseases with dermatologic manifestation also. So out of these, you know that just within WHO has recorded around 20 NTDs. So within those cluster of neglected tropical diseases, many of those diseases involve the skin. And 18 of these 20 neglected tropical diseases have a well-known cutaneous manifestations. And out of these, around 9 of them actually primarily present with skin presentations. And as you can see, these are like mucocutaneous and mucocutaneous leishmaniasis, leprosy, onchocerciasis, the deep fungal infections, especially chromoblastomycosis and mycetoma, and ectoparasite scabies and ectoparasites, the lymphatic filariasis and podoconiosis, VOs, and what's not here is actually also the Bruley ulcer, which is not common in Ethiopia. So as you can see from this picture, almost all of those diseases, they may not be fatal, but you can see how much they are disfiguring, disabling, and also have a great psychosexual impacts on the affected individuals. So, but one thing is that, you know, that in neglected tropical diseases, on their management, there is 2 categories. The one are those who can be managed by specific chemotherapy, that is either they can be given the preventive chemotherapy, and the other is morbidity management and disability prevention. And so, like the other entities, skin entities also, they can be divided into 2. Those who can be managed by preventive chemotherapy and those who can be managed also by morbidity management and disease prevention. From those who can be managed with preventive chemotherapy, mass drug administration, especially in NTD, is one of the main mechanisms to control those neglected tropical diseases. But unfortunately, most of those skin entities, they will not be managed with mass drug administration alone, but needs an individual case management. So the diseases have been more, especially those who needs an individual case management, like lymphatic filariasis and podoconiosis, and also mycetoma and other deep fungal infections. They have been more neglected compared to those that could be predominantly targeted by mass drug administration. Furthermore, it's important to recognize that even for those diseases that are targeted by mass drug administrations, individual case management is an essential need of those affected. And this is typical, especially when you see the lymphatic filariasis. Usually there is an ivermectin mass drug administration for the prevention of lymphatic filariasis and also acute management. But once the individual has developed lymphedema, or what we call it elephantiasis, definitely there is a need for an individual case management, especially disability prevention and morbidity management. So the MDA doesn't address the long-term consequences of those diseases. And to address those gaps, following the WHO roadmap 2021-2030, WHO has created a platform for those and neglect the skin NTDs with including skin diseases that are beyond skin NTDs. Practically, those skin NTDs or the skin diseases beyond the skin NTD means those skin diseases of the poor, especially like fungal infections, superficial fungal infections. So on this, the WHO skin NTD documents in the umbrella of skin health for all, with the goal to reduce the morbidity, disability, and psychosexual impact of skin NTDs and other conditions through people-centered integrated approach. It puts 5 objectives. And the first objective is to adapt and implement integrated skin NTD strategies based on local endemicity and needs. And the second is strengthen person-centered skin NTD services and care. The third, enhancing disease surveillance for skin NTDs and wherever possible, other skin conditions. And the fourth is strengthening monitoring and evaluation of outcome and impact of integrated strategies. And finally, enhance advocacy, coordination, partnership, and national ownership towards aligning targets. So just taking those objectives, if we start to talk about the rationality of integration is, in integration, the first thing is, this is just because of the co-endemicity of most of those skin NTDs. Actually, not only the skin NTDs, practically they have some co-endemicity because these are the diseases of the poor. Ethiopia registering around 18 of the skin NTDs from the WHO list. The same goes through also for the skin NTDs. In most the rural and even urban part of the country, you have rhoconiosis, scabies, and myxotoma together, and other skin NTDs. Same goes also for an area endemic for lymphatic filariasis, is also in some places endemic for onchocerciasis. The other thing is those skin NTDs share clinical characteristics, especially skin lesions, and also their consequences, especially disability and other psychosocial issues. And those skin NTDs also, integrating them is very much essential for developing country, sharing resource efficiency and cost effectiveness, strengthening the disease surveillance and data management, integrating training and enhancing healthcare workers' knowledge and skills, reducing the stigma and discrimination, and heightened advocacy and commitment by integrating those diseases and improving coordination and collaboration among different stakeholders, and finally, improve visibility of the result. But when we're saying this, it doesn't mean that everything is rosy. There is also downside of this, the challenge of integration. When we are talking integration, one thing is that especially it means when we are talking about skin NTDs, the management has to be decentralized. That means instead of specific training, we have to expand the knowledge of those health workers, and that makes retention of the expertise a bit difficult. And the other thing is avoidance of dismantling the existing vertical programs, especially when we are talking NTDs. Most of them, in the programs, they are vertically managed, You have the STH program or soil transmitted helminthes. You have the oncolymphatic filariasis program. You have the trachoma program, and so on. But in skin NTD, it's coming just, the concept is to manage those skin NTDs together. And overloading of healthcare workers, especially primary healthcare workers, loss of focus for donors and partners. Usually donors and partners, they want to see the results immediately, and they want to focus on some diseases, and expanding on integration do have certainly some problems, even though the long-term outcome is actually much better. And the other problem is sustaining political commitments and sustaining domestic funding. So from this global context background, when we come back to Ethiopia, our experience, just to give you the background of the country, this is a country which its landmass around, well, it can cover around 10 and more than 10 parts of Europe, with 120 million population. But one thing significant here is, as a developing country, we have the lowest per capita health expenditure. That is 33.2 USD. Even this is even lower than for the average of sub-Saharan African countries. And the under 5 mortality rate in the country is 55 per 1,000, and childhood coverage of all basic vaccination is less than 50%. But you can see that, and one of the big issue is more than 1/3 of under 5 children in the country are stunted. And the country do have the lowest healthcare worker, 1.4 per 1,000. Even this is lower for the WHO and sub-Saharan African countries. So with this context, bringing skin NTD management in the country, the issue is there will be a prioritization. So when we are thinking managing skin NTDs, we're sharing all those resources. And so we try to look actually what it is the proportion of those skin NTDs in just the routine clinic, which is happening. And this is the work of Said and his colleagues, Said and us, and try to assess, to look into a record of 656 patients who has been seen in one of the medium dermatologic center. And from this operational research, we found that around 1/5 of the patients who are coming to the dermatologic centers do have skin neglected tropical disease. And the most commonest skin neglected tropical diseases coming to the clinic are cutaneous leishmaniasis, leprosy, scabies, and mycetoma. But at the same time, as experts, we know that this number actually most probably is misrepresentation, very lower than actually what is in the real world. If we see the cutaneous leishmaniasis, we know that from other studies, most of the cutaneous leishmaniasis patients, because of the limited treatment access and the limited drug available, and cutaneous leishmaniasis being treated only in treatment centers, not in most of the hospitals, patients, they don't come to the attention of the healthcare. Leprosy, well, Ethiopia is one of the countries who is actually reporting now a leprosy with disability, with highest first grade and second grade disability. So the patient, this shows you that actually patients are presenting late. Scabies, and one of the issues behind this is that actually in the country, and as the other part of the world, the scabies has become normalized, and patients may not come to the hospital. Compared to the community-based studies, we can see clearly that the percentage of patients with scabies who are coming to the hospital is very low. Same goes true also for mycetoma. So with this data, you can see that actually one thing which this data shows us is that even though this is the tip of the iceberg, still 1/5 of the patients, dermatologic patients with skin NTDs, we call it a higher number. So after this, I'm going to talk about just what we did, especially to test on the feasibility of community-based intervention. Because if you remember, we said that the country to have the lowest number of health workforce. So with this health workforce, using the routine program, it's really difficult to address the community. So we have to really redesign the system to manage a large number of the population with the skin neglected tropical diseases. So we use certain examples. I will be presenting here 3 examples: scabies, the deep fungal infection, and podoconiosis. So our scabies experience is in 2015, following the El Nino-associated droughts. There was a report of scabies outbreak, and especially in one of the region, the Amhara region, and around 68 districts, or we call them locally Woreda, were affected by scabies. And each district has, in average, a population of around 100,000. So this means we are talking about around 6.5 to 7 million people. So with a lower number of health workers, and also actually in the same region, there were only 4 dermatologists at the time of this outbreak. That means practically this is a region with around 20 million population. So with this limited number of dermatologists, even limited number of physicians, at that time, the number of physician to population ratio in the region was 1 physician to 30,000 population. It is unimaginable to manage a community-based outbreak of scabies. So what we did is we trained the health extension workers. We used the primary health care system existing in the country, trained the health extension worker with the 1 day, just giving them the essential tools in diagnosing and treatment of the scabies. And in 1 month period of time, the health extension workers has screened around 1.1 million individuals from those 68 districts and identified around 379,000 scabies cases. And following this, actually, because this was the first time we were using health extension worker in diagnosing dermatologic issues, we tested the agreeability of the diagnosis of health extension workers with the dermatologists. And we found that actually 98.3% of the diagnosis of the health extension worker were agreeable or just the same as that of the dermatologists. And at the same time, we used those health extension workers to administer treatment for 820,500 cases and contact of scabies. So following this, this study has shown us actually in a resource-limited setting, we can use primary health workers, health extension workers. These are grade 10 students plus training for 1 year with a certain healthcare package. We can use those healthcare workers and to decentralize the management of one of the skin neglected tropical diseases. The next thing we have done is actually, after a year and a half of using those health extension workers, we tried to look into the effectiveness of their management. So we did a desk review and we interviewed around 7,562 participants from 3 zones and the district who has been affected by scabies. And in this, we found that actually following the administration of the individual management and mass drug administration by health extension workers, the cure rate was 90.6%. And this is actually an effective, or we call it a higher cure rate. So this result has come because of in area where there is higher community engagement, political commitment, and adherence to the guideline, where the factor in the successful scabies mass drug administration and control. But in a zone with the worst health system, especially in the northern part of the country where there is a security problem, also a poor infrastructure and lower community engagement, the prevalence actually has increased from around, at that time, 28% at time of treatment to 46.1% after 1.5 years. So using those studies, 2 studies, one thing we have concluded is that, okay, we can use the health extension worker in diagnosing scabies, and the health extension worker are effective in identifying the skin disease. And also we can use the same primary healthcare structure in managing scabies. But we want to see actually what about to see the effectiveness of this mass drug administration in a larger community. So in 2018, we again there was a scabies outbreak. So in 2 weeks period of time, we used actually 14,796 health workers. These are both health extension workers, nurses, and physicians and health officers, plus also other support groups, and reached in screening around 9 million people. And by screening about 9 million people, a total of 875,890 scabies cases was identified, and 995,471 contacts are identified, and most of them have received treatment. And this happened actually in 2 weeks period of time, and we evaluated actually the cost effectiveness of this campaign, and the cost of managing a person with such campaign was around $1.29 USD per person. And this experience of conducting a rapid large-scale scabies campaign implementation, actually at that time we concluded that be useful to scale up similar intervention nationally and also for the global community. And at this time, this was actually the time even before, especially the 2015, even the WHO was contemplating about mass drug administration for scabies. And so Ethiopia was one of the open country, not an island country, to demonstrate that this mass drug administration of scabies can be effective. And if we are going to use mass drug administration or what we call it the preventive chemotherapy for scabies, one of the things is, can we integrate it? And how can we integrate the scabies management? So these are some of the outlines actually how we can integrate scabies management, especially during the MDA or during the NTD program in general. So you can see that the scabies campaign, NTD, on mass drug administration can be integrated with those all NTDs with preventive chemotherapy is effective. That is LF, onco, schisto, STH, and trachoma. You can see that the integration can happen during strategic planning, mapping, training, the logistic drug supply chain, and drug distribution, especially with LF and Onco, and also the Schisto and STH, and the monitoring and evaluation and morbidity management, well, in a certain way can be integrated. And the other diseases we try to look from the community management. What about those diseases which has to be treated in the hospital level, that is an individual management? And this is the subcutaneous mycosis. So one of the issues with subcutaneous mycosis or mycetoma and the fungal infection in our country is that even though this disease has been labeled as NTD by WHO since 2016, and there was, well, Ethiopia is one of the countries in what we call it the mycetoma belt area, and actually the neighboring country for Sudan, bordering around 720 kilometers. And Sudan is one of the countries which has reported the highest number of mycetoma in the world. But unfortunately, as you can see from this global map, which has documented a mycetoma case report from 1876 to 2019, Ethiopia, there is no mycetoma reports or the fungal infection reports recorded in the WHO website. So as a result, Ethiopia is not in the map of mycetoma, but at the same time, there is WHO considered Ethiopia as one of the countries. So the recommendation was with the global initiative to estimate the burden and map of the distribution of the disease in the country also. So as you can see, while for many other countries, including Ethiopia, no strategy can be devised because of lack of epidemiological information. And what we did is just last September and October with my colleagues, we were commissioned by WHO, Africa region and country office with the Ministry of Health to do a rapid assessment of the burden of subcutaneous mycosis or mycetoma and fungal infection. So we did a retrospective assessment to identify all suspected and confirmed cases of fungal infection in the country, especially from, and we went through the data from 2015, 2020, and went through 13 referral hospitals in six regions, both from north, south, east, west of the country. And the result of this study is that we found a record from 3 years, from 2018 to 2021. And actually, the results have shown that Ethiopia is one of the country with endemic for fungal infection, both mycetoma and other fungal infection. But the prevalence is a bit lower, much lower than what's reported from Sudan. But the distribution in the country is much higher in the northern part of the country, which has in the north, especially Amhara and Tigray, taking more than 2/3 of the case of the burden of mycetoma. But this, again, this hospital-based study may show us the tip of the iceberg. And but at the same time, it can be a proxy indicator and help us to put Ethiopia in the map of mycetoma. That's what we did. And you can see some of the different clinical picture we have found. It can present from a simple sinus and nodule to an infiltrative lesion, a distraction with both. And it can present with sporotrichoid presentation. And also, actually, we reported case of sporotrichosis and also other fungal infection like chromoblastoma. The third example I would like to bring with a different form of management, what we call it the morbidity management and disability prevention, is the experience from polyposis. So for this, I'm bringing the as example, our community practice in 2012, we started the a podoconus prevention and control program in one of 60 kilometers from Bahar Dar. And in a single Saturday, when we started the program, actually, we registered more than 240 patients from the local who has come to the health center for treatment. And so treatment and health education initiated in collaboration with the local health center. And one important thing we did here is 1 year into the program, the patient association took over most of the care and education. The first treated patient has become the strong advocates for management and the prevention. Medical students from the my college were involved in the healthcare education and so on. And this is the example I would like to show you actually with the community engagements, which is one of the flagship for the WHO roadmap. And 4 years after starting the program, more than 400 patients have been graduated in self-care for their lymphedema. So to support those, especially in one of the issues with podoconiosis is that it's neglected by the policymakers, it's neglected by the scientific community, it's neglected also by even by the community, by the funders. So one of the things we were supposed to do was evidence generation. So the first evidence generation we did is actually to, there are some publications on podoconiosis. A lot has been done actually in 1970s by one of the physicians, and then that was most of the clinical findings. And later on, after the millennium, especially the burden of the disease, the epidemiological distribution, and so on, it was worked by Gail and her colleagues. But the clinical presentation of podoconiosis and also the cause of the etiology of the disease and the pathogenesis of the disease is still unknown. So we did some study on the clinical spectrum and the microscopic presentation of the disease and also the histopathological immunochemical feature of podoconiosis. And one thing actually during those community work and the study, one thing we have found is usually when we are advocating for the lymphedema management, we are advocating about the foot care, leg elevation, massaging, bandaging, and shoe wearing. But we found that actually around 40% of patients of podoconiosis patients, they have nodules in their foot or lower leg, which may create a difficulty in wearing shoe and also applying for the bandaging. So unless otherwise, those nodules will be managed surgically. And one of the issue is classically, most of the surgeons will avoid doing surgery on lymphedema patients because of the assumption there will be a delayed wound healing and complication because of the compromisation of the lymphatic drainage and immunological responses. But in our study, we have proved that actually surgical nodulectomy can save the foots, and the epithelialization of those surgical nodulectomies is almost equivalent to the normal population. And these are some of the findings from the clinical presentation and the microscopic presentation of podoconiosis, and these are the surgical outcome on one of our podoconiosis patients. You can see that how the patient has presented. Primarily, actually, when the patient presented for the first time, he was seen by orthopedic physicians, actually more than one orthopedic physician, and both of them has recommended for a leg amputation. But by doing a limited surgical nodulectomy, as you can see, you may not have really beautiful leg and foot, but at least you can have a functional leg for this young person. And when we're talking about PODO, and when we're advocating for PODO, one of the things is that PODO is a problem only almost just for those who are going barefooted. So PODO can be preventable 100% with shoe wearing. But the challenge we have found from our clinical practice is that actually in the last 7 years, we start to see a vitiligo type of lesion on those individuals who are wearing a plastic shoe. And this can be actually because the Ministry of Health in its guideline or the NTD strategic plan, they have documented that PODO can be eliminated in 2030 by, first it was actually in 2025 by advocating for shoe wearing. But why we are advocating for shoe wearing, one of our study has flagged is actually we have to address also the issue of the shoe. And this is very much important because vitiligo is also one of a stigmatized disease in our country. And in conclusion, because of the visibility and the relative ease of diagnosis with small training, cutaneous sign and symptom have been proposed as entry point for integrated neglect tropical disease diagnosis and management, especially for skin. And it is the integration control activities. There are a need for strong scientific evidence on the provisional control of strategy of most skin NTDs, and our study has demonstrated skin NTD management and control can be decentralized by task shifting, especially for primary health workers, and community skin disease diagnosis and management, advocating for political engagement and enhancing community participation. And the way forward I'm suggesting is there is, especially for Ethiopia, there is a national map, there is a need for national mapping of skin NTDs and their burden. It's important to develop a routine program for identifying and recording cases of skin NTDs at the primary healthcare level and revisiting the health management information system or the district health information system indicator to capture skin NTDs in general in the country and intensify effect in terms of public awareness, education of community workers and health professionals, and leveraging especially artificial intelligence to primary health workers, education and decision support for neglect tropical disease diagnosis and management is what I'm recommending. And that's all what I have. Thank you.
Thank you, Wende. We received a couple of interesting questions, a couple related to skin NTDs and a few related to NTDs in general. Wende, the first one is about a colleague from the Somali region. Well, I'll come to that one later. First one is on poroconiosis. There was a question about how can you rule out poroconiosis in clinical practice? Is it a clinical diagnosis? Do you need lab testing? How does it work?
So for poroconiosis, it's a clinical diagnosis. We don't have really a field-tested diagnostic mechanism. It's a clinical diagnosis. And the most important thing we have to know is just because the most important differential diagnosis for PODO is lymphatic filariasis. And it can be, and the thing is, the geographic distribution of PODO is different from that of lymphatic filariasis. And plus also PODO, usually it starts from the lower feet or the foot, and lymphatic filariasis usually starts by from the lymph node, especially the inguinal lymph node, and it involves only one of the leg. PODO, even though it's asymmetrical, it involves both of the leg. And lymphatic filariasis, usually you find it in lymphatic filariasis endemic area. In PODO, usually in the highland part of the country. And those are some of the differential or the clinical differentiation from the other thing is from what about from systemic illnesses? And this is actually from systemic illnesses, most of the time, the patient with systemic illnesses has other manifestations. So in conclusion, the diagnosis is clinical, and there are certain criteria actually which can are used to differentiate between podo and lymphatic filariasis, because this is the most important here.
Okay, thank you, Wendy. And you mentioned patients with NTDs and skin NTDs, well, they tend not to present to the hospital. It's only the tip of the iceberg. So is it something which can also be diagnosed or at least recognized at the decentralized level? How would you see that?
Yeah, that's the most important thing, because if we just untangle this and see why they are not coming is a different issue, and which I have stated previously. And the first thing is it can be the stigma, and the other thing is the access, because and the third thing is even if they come to the health facility, the treatment may not be available. But surprisingly, most of the skin NTD actually can be diagnosed easily, even by the patient. From our society perspective, actually, I can see that if you see cutaneous leishmaniasis, the community has a different name. They know it's cutaneous leishmaniasis. They will not tell you it's cutaneous leishmaniasis, but it has a specific name. So sometimes they are actually much better than even physicians in diagnosing cutaneous leishmaniasis, even scabies, and so on. So with a smaller skin, if the community is able to diagnose cutaneous leishmaniasis and scabies, and also podoconiosis, why not the community health workers? Though that's the thing. With a smaller skin, actually, you can outsource the diagnosis and management of those skin entities.
Thank you, Wendy. Maybe without going into too much detail, there was a question about mycetoma. Is it like a skin NTD, and do you have different types, and which one do we have in Ethiopia?
Well, it is a skin NTD which has been registered by WHO since 2016, and practically it was registered as mycetoma and other deep fungal infection or other subcutaneous fungal infection. So the country which has reported the highest number of mycetoma or deep fungal infection is Sudan, our neighboring Sudan, which has reported more than 10,000 cases actually in the last 10-20 years. And the clinical presentation, we have tried to look into the clinical presentation of mycetoma. More or less, the clinical presentation is the same with the reports from Sudan and other neighboring countries. It's not like that of cutaneous leishmaniasis, which have an old world or new world cutaneous leishmaniasis. In mycetoma, the presentation which we have found is more or less the same, but we did find actually the different clinical presentation of mycetoma.
Okay, thank you. There's another question, a colleague from the Somali region is wondering, like, well, in some areas in the world and also in Ethiopia, they're very, the health system has a lot of limitations, and there's also maybe not always as much attention from the policymakers. So what can they do to diagnose NTDs? Because they have limited tools, so how can they proceed?
That's actually why the focus of this presentation, also the development of the WHO skin NTD guideline, how we can decentralize the diagnosis and management of skin NTDs, especially those skin NTD with no diagnostic tool, which can be diagnosed mostly clinically. So that's the most important thing. And that one of the thing I was talking previously was most of the skin entities actually, they can be recognized easily, and they can be trained with one-day training for primary health workers. Even the community knows them actually. For example, if you just list the commonest skin entities in my country, cutaneous leishmaniasis, scabies, and onchocerciasis, and lymphatic filariasis, and podoconiosis, The community gives them a different name, but they know them, even though they don't have the scientific name. If the community knows them by just developing a small tool, you can train also the health extension. On the management, the most important thing is that's the case. And most of the skin NTD as the disease of the poor, their management also, they can be managed with the available tool in the community by just using water, leg elevation, massaging, and also they can be managed with mass drug administration like scabies. And the most important thing is those drugs are available for other NTDs. So one way we can use is leveraging the resource we have from other NTDs for the skin NTD management.
Okay, Wendy, I'll have one more question, and then I think there's someone in the audience who also would like to directly ask a question. Maybe the online question first is, yeah, traditional healers, traditional medicine is where most patients or individuals first go. So what can be their role? Can they be part of the control or the improved management of NTDs or skin NTDs?
Well, the thing is, while we are saying that some of those NTDs are known also with the community, that means traditional healers also knows them. And again, I will take typical example of the cutaneous leishmaniasis and how traditional healers manage them, especially in the southern part of the country. They use a different leaf, and they use some cauterization with leaves and so on. So you can see that in some, the cutaneous leishmaniasis is healing. It may be because it's, in some cases, it's self-limiting, or it may be because of the work of the traditional healer. And one thing, what's important is we have to value those traditional healers, but as a scientific community, we have to also test the drug or the tool they are using for the effectiveness of those skin NTDs.
Thank you. We have a colleague who would like to directly ask a question. Charlotte, can you allow him in, or her? So I think it's a question from Tatfe. I think if you unmute yourself, Tatfe, then you can ask your question. Tatfe?
Yeah, I have no question.
Okay.
Yeah,
Okay.
I have no question. Thank you.
Okay, no problem. We saw a hand, but it's okay. Wendy, there's a couple of more interesting questions. One is about, yes, I think it's also in the setting of Ethiopia, like leprosy used to be integrated within TB, at least in the manuals. So do you also see like a role, if it's already integrated there, do you see a role of integrating then it more in skin NTD management? What is your view?
Well, as you know, leprosy used to be a vertical program, and then integrated with tuberculosis. But after the arrival of HIV, tuberculosis has married a new wife, that is HIV, and leprosy left alone. And that made leprosy actually one of the neglected diseases in the country even. And in the last, actually, the National Strategic Plan, or the NTD strategic document, leprosy was not included in the country even. So including leprosy with other skin NTDs, the thing is, it's just the manifestation of those leprosy, the cutaneous manifestation, plus also the stigma it has, shares similarity with other skin NTDs. So it can bring out, we can use the resource of other skin NTDs and leprosy for the identification of leprosy, for mapping and also for management.
Okay, I think we have time for one, maybe two questions. One is, yeah, you mentioned artificial intelligence. So the question was, yeah, how feasible is this at the primary healthcare level? How could it be applied or used?
Well, we are actually already practicing it. The thing is, the first thing, if you remember, since 3 years back, WHO has developed a skin app program, which was adapted from other partners. And this skin app program is being used now by a lot of primary health workers, and at the same time for a diagnosis of skin NTDs and other related skin diseases. Plus, also it's being used for training. And the artificial intelligence, especially if one of the things we are doing, one of the work I'm involved in now, actually, we are feeding pictures, images of skin NTD for artificial intelligence, and so that it can help in a decision-making for primary health workers. So most of primary health workers, we know they have a mobile phone, and those mobile phones, they can take pictures. And with the help of artificial intelligence, that picture can be interpreted. And with certain algorithm, they can reach or they can be helped in decision-making in this arena. Thank you.
Okay, thank you, Wendy. I think we unfortunately have to close here. So by this, I would like to, of course, Wendy, many thanks to you to be with us on NTD Day today. Special thanks to the audience, and thank you for joining and showing your interest in NTDs and skin NTDs. And also thanks to my colleagues here at ITM for putting everything together. Charlotte, anything back to you?
Yes, I just would like to say also a big thank you to Wendy for sharing your research findings and insights. Also to Johan for moderating this webinar. Also to Maria for assisting us with the management of the questions. Also a big thank you, of course, to you, the audience. Also for completing the poll, and make sure you be there as well for our next upcoming webinar on the 13th of February, same time from 1 till 2, a webinar organized in light of the International Day for Women and Girls in Science with PhD alumna Dionisia Gamboa from Peru. So save the dates. In the meantime, stay safe and healthy, and looking forward to seeing you back. Thank you very much to all, and for attending and for your insights. Thank you, Wendy. Thank you, Maria.